Welcome to the deep dive. Our mission here, as always, is to take complex, really detailed source material and transform it into professional level knowledge for you, giving you real mastery over topics that often get simplified or just, well, overlooked. Today, we are undertaking a serious deep dive into the Puerperium. Now, for those maybe less familiar with the term, this is that complex 6-week biological process right after childbirth. People often call it the fourth trimester, kind of affectionately. But it's not just about recovery, it's really a physiological masterpiece. The body orchestrates this massive systemic reversion. We're pulling from an incredibly detailed textbook excerpt today, really dissecting every single anatomical, physiological, and hormonal shift. Our goal, to get you that professional level understanding of this whole 6-week reset.
That's exactly right. To really master this period, we have to look beyond just healing.
Yeah.
We need to understand the intricate mechanics. This is a rapid, highly organized biological reversion process. And the core mechanism, the key word here, is involution. So we're going to explore the precise biochemical, the anatomical processes that govern how the reproductive system trying to hit that reset button. Shrinking organs, obliterating blood vessels, rebuilding entire tissue layers, all in just a matter of weeks. It's quite something. #TagIFA. Defining the Puerperium and involution.
Okay, let's start with the basics then. Nail down the hard definitions. What is the strict medical scope of the puerperium, and how does that differ from this broader idea of the fourth trimester?
Right. So formally, the puerperium is defined as the period following childbirth during which the body tissues, particularly the pelvic organs, revert back approximately to their pre-pregnant state. That's both anatomically and physiologically. It kicks off immediately after the placenta is expelled and typically lasts for about 6 weeks. And the woman during this time, clinically, she's referred to as a puerpera.
Okay, puerpera. And within that 6-week window, you mentioned clinicians use specific time divisions. Arbitrary, you said, but why are they important?
Yeah, they seem arbitrary, but they really help track the expected progress. And crucially, identify when things might be going off track. We break it down into 3 stages. First, the immediate puerperium. That's just the first 24 hours postpartum. Then, the early puerperium, which goes up to 7 days. And finally, the remote puerperium, spanning the period up to 6 weeks. These divisions basically allow healthcare providers to know, for instance, exactly how much the uterus should have shrunk by the end of week 1. Helps catch complications early.
Makes sense. So if the puerperium is technically 6 weeks, why do we hear the term fourth trimester so much these days? What's the difference?
The fourth trimester is a bit more encompassing. It's a more holistic view.
Yeah.
It includes the time from delivery until not just complete physiological involution is achieved, but also until the mother's psychological adjustment is complete. So it acknowledges that the mother's full return to her baseline isn't just physical. It brings in mental health, emotional bonding, adapting to parenthood. It's broader.
Got it. Physical and psychological. Now, you mentioned deviations from this highly choreographed process, specifically subinvolution and superinvolution. Subinvolution seems straightforward. Things don't revert fully. But superinvolution, that sounds like an overcorrection.
It does, doesn't it? Superinvolution is basically an accelerated or excessive shrinkage. And interestingly, this phenomena is often seen in women who are lactating, who are breastfeeding. It seems the continued hormonal environment associated with breastfeeding can actually cause the uterus to become even smaller than the typical non-pregnant size. But, and this is important, our sources note this state is temporary. If lactation is stopped, the uterus eventually reverts back to its normal non-pregnant size. So it's a temporary lactation-driven anatomical change. Really shows how responsive the uterus stays to hormones even after its main job is done.
Okay, the uterus. It's undeniably the star of this whole reversion show. We're talking about arguably the fastest and most massive non-pathological shrinkage in the entire human body. That's incredible. So walk us through those immediate post-delivery stats. What does it look like right after birth?
Right after the baby and placenta are out, the uterus goes into this state of intense contraction and retraction. It gets very firm. You can actually feel it alternating between hardening and softening phases. And its dimensions right then, they're enormous, roughly 20 centimeters long, 12 centimeters wide, and about 7.5 centimeters thick. But the really critical number is the weight, around 1,000 grams. That's a full kilogram.
A kilogram. A kilogram of tissue that somehow needs to be almost entirely disposed of or repurposed within just 6 weeks. Where does it all go?
Exactly. By the end of that remote puerperium, 6 weeks later, it's achieved almost non-pregnant dimensions. And the weight, a mere 60 grams, that 940-gram reduction. That's the anatomical benchmark of successful complete involution. It's this dramatic exponential curve of shrinkage.
Just incredible. And what about the lower part of the uterus, the segment that got so stretched and thin during labor?
Ah, yes, the lower uterine segment. Immediately after delivery, it's described as thin, flabby, kind of collapsed. It actually takes several weeks to fully organize itself and revert back to the normal shape and, well, the small size of the isthmus. That's the connection point between the main uterine body and the cervix. The cervix itself is also changing, but it contracts more slowly than the main uterine body, the fundus. By the end of the first week, the external os, that's the opening, has narrowed down quite a bit. It would only admit, say, the tip of one finger. However, and here's a really crucial anatomical detail, a permanent physical legacy of childbirth. The external os never reverts back to its nulliparous state. That small circular opening you see in women who haven't given birth vaginally, it becomes a transverse slit, like a line across. That's the lasting physical signature of the Paris woman.
Right, I remember learning that. It's a detail professionals can use for a quick clinical assessment even years later. Okay, so let's talk about tracking that huge 940-gram reduction clinically. How do professionals actually assess the rate of uterine involution day by day?
We use external measurement. It's quite straightforward, actually. The procedure involves noting the height of the uterine fundus, that's the top of the uterus, in relation to the symphysis pubis, which is that bony joint right at the front of the pelvis. But to ensure reliability, this measurement has to be taken daily, ideally at a fixed time, and, if possible, by the same observer to minimize variability.
And the source emphasizes that preparation is absolutely critical here. What could possibly skew the assessment of that fundal height?
Right, anything that pushes the uterus up artificially. So any distended neighboring organ. Therefore, the bladder must be emptied beforehand. Preferably the bowel, too, especially if the patient is constipated. If you don't do that, you could get a falsely high reading, which might mask a failure of the uterus to contract properly. It could hide a problem. The progression itself is remarkably predictable. Immediately after delivery, the fundus sits about 13.5 centimeters. That's roughly 5.5 inches above the symphysis pubis. That height stays pretty constant for the first 24 hours. After that, there's a steady decrease in height by a very measurable 1.25 centimeters, or about half an inch, every single 24 hours. This predictable rate means the uterus sinks back below the pelvic brim and becomes a pelvic organ again by the end of the second week. You can track it almost like clockwork.
Okay, the anatomical facts are stark. A kilogram down to 60 grams. But now we need to get into the how, huh? What's the physiological machinery driving this incredible shrinkage? We need to look at the muscles, the blood vessels, and the endometrium lining. Let's start with the uterine muscles themselves.
Right, the muscle changes are maybe the most counterintuitive part. During pregnancy, those individual muscle fibers underwent massive growth hypertrophy, it's called. They enlarged up to 10 times in length and 5 times in breadth. Huge cells. But here's the absolute key point. The number of muscle fibers does not decrease during the puerperium. The immense size reduction is achieved entirely through the substantial shrinkage, the reduction in size of the existing myometrial cells.
So the cells aren't dying off, they're just shrinking dramatically. What's actually digesting all that extra cytoplasm they built up during pregnancy?
That's the process called autolysis. It means self-digestion, and it's chemically mediated. The mechanism gets triggered by the withdrawal, the sudden drop in those high levels of pregnancy, steroid hormones, primarily estrogen and progesterone, right after delivery. This hormonal shift dramatically increases the activity of an enzyme called uterine collagenase and prompts the release of other powerful proteolytic enzymes, protein-digesting enzymes. These enzymes basically facilitate the self-digestion of the protoplasm within the muscle cells. As that protoplasm breaks down, it liberates components known as peptones. These peptones then enter the bloodstream and are subsequently filtered out and excreted by the kidneys, primarily as urea and creatinine. Wait a minute, so the physical breakdown of the uterus muscle, you can actually measure that chemically in the mother's urine. Precisely. The increased excretion of urea and creatinine found in puerperal urine is a measurable systemic byproduct of that massive physiological breakdown of the uterine muscle mass. It's a direct chemical link between what's happening in the uterus involution and the mother's overall metabolic state. Quite elegant, really.
It really is. And what conditions inside the uterus itself help this rapid autolysis happen efficiently?
2 main conditions are needed. First, just the effectiveness of those enzymes we just discussed. They need to be active. Second, a state of relative anoxia, basically, a lack of oxygen. And this anoxia is actively induced by the uterus's own powerful contractions and retractions after delivery. These clamp down on blood vessels, restricting blood flow to the muscular wall. This low oxygen environment turns out to be perfect for these enzymes to work efficiently without needing a huge blood supply during this rapid breakdown phase.
Fascinating. Okay, let's shift focus to the circulatory system within the uterus, especially at the placental site where all those big vessels where they need to be shut down completely, right?
Absolutely. Those vessels that supplied the placenta need a radical overhaul. The change is most pronounced right where the placenta was attached. What happens is the arteries supplying that area undergo immediate constriction just from the muscle clamping down. But that's quickly followed by several highly organized cellular events. The intima, the inner lining, thickens. Then you get thrombosis, clotting, hyalinization, which is like scarring, and something called fibrinoid endarteritis. All of this happens rapidly just within the first week. Similarly, the veins get obliterated by thrombosis, hyalinization, and endophlebitis inflammation and clotting within the veins.
Wow, it sounds like the body is actively welding shut the plumbing it doesn't need anymore. But you said our source mentioned something interesting about regeneration. It doesn't just replace the old vessels.
That's right. It's a really clever bit of biological engineering. It's like instant structural repurposing. Instead of the old thick-walled vessels being entirely absorbed and then replaced by new growth from the outside, new, smaller blood vessels actually grow inside the thrombi, inside the clots that have blocked the old redundant vessels. This method ensures really efficient vessel replacement while maintaining the structural integrity of the uterine wall. It avoids sudden weakness or potential hemorrhage points.
That makes perfect sense. Protects against hemorrhage and structural collapse. Okay, finally, the endometrium, the lining that supported the whole pregnancy. What's the timeline for its restoration?
Right, the lining. Most of the decidua that specialized pregnancy lining gets cast off with the membranes in the placenta. What's left is a thin layer, maybe 2 to 5 millimeters thick, and this begins to regenerate rapidly. The superficial necrotic part of this remaining layer actually forms part of the lochia, the discharge we'll talk about soon. Regeneration kicks off quickly, starting by the 7th day postpartum. It originates from the epithelium lining the mouths of the uterine glands and also from the interglandular stromal cells. And the speed is remarkable. The epithelial restoration, just the surface layer, is completed by day 10, and the entire endometrium is functionally restored by day 16.
Day 16. That quickly. So the vast surface area of the uterine lining is essentially back to normal in just over 2 weeks.
Functionally, yes, for most of it. However, there's one major exception: the placental site. Because that specific area sustained the deepest implantation trauma and requires the most complex restructuring. It takes the full approximately 6 weeks for complete restoration. So that 6-week timeline for the whole puerperium is largely dictated by the slow, meticulous healing needed at that placental implantation site. #43, involution of other pelvic structures, and lochia.
Okay, while the uterus is doing its incredible shrinking act, the surrounding pelvic structures, the vagina, the ligaments, the whole pelvic floor, they also took a massive hit from the stretching of pregnancy and labor. How do they recover?
Yes, they definitely undergo significant changes too. The vagina, being highly distensible, takes a relatively long time to involute, typically 6 to 10 weeks. And while it does regain significant tone, structurally it never quite returns to the virginal state, who remains permanently altered. Critically, the vaginal mucosa, the lining, remains delicate for a while, and the submucous venous congestion, basically swollen veins beneath the surface, persists longer than the muscle recovery. This lingering congestion is the clinical reason why non-essential surgery on the vagina is usually postponed for quite some time, often up to 10 weeks or even longer. You need that tissue to settle down first.
Makes sense. What about those permanent physical markers in the vaginal area? You mentioned the cervix changes permanently.
Right, so the introitus, the external vaginal opening that remains permanently larger after a vaginal birth. And the hymen, which is lacerated during delivery, isn't really there anymore. It's represented by small, residual nodular tags of tissue. These are called carunculae myrtiforms. So these caruncles, along with that transverse slit in the cervical os we talked about, provide clear, permanent anatomical evidence of parity that a woman has given birth vaginally. Furthermore, the supporting structures, things like the broad and round ligaments, the pelvic floor muscles, the pelvic fascia, they all require considerable time to recover their tensile strength and tone after the significant stretching and, well, laxation they endured during delivery. This recovery timeline is really what dictates when a woman can safely resume certain types of strenuous exercise.
Right, that links back to the exercise section later. Okay, let's shift gears to a key diagnostic marker of puerperal healing, mavolotia, that vaginal discharge. What's the typical character and total duration of this discharge?
Lochia is the discharge you see for roughly the first fortnight, maybe a bit longer, during the puerperium. It originates from the healing uterine body, the cervix, and the vagina. It characteristically has a peculiar offensive smell, almost fishy. That's considered normal, believe it or not. Chemically, it starts off alkaline in reaction, but it tends to become more acidic towards the end of the discharge period. The average total amount shed in the first 5 to 6 days is around 250 milliliters, and the normal duration. It can extend up to about 3 weeks.
Okay, 3 weeks. And it's the color shifts, right? They really tell the story of the internal healing process. Can you walk us through those 3 stages, linking the color to the actual composition?
Absolutely. These 3 distinct stages are essential clinical milestones to watch for. First, you have lochia rubra. That's the bright red discharge. It lasts from day 1 through about day 4. Its composition really reflects fresh, bloody output. It consists mainly of blood, but also shreds of fetal membranes and decidua. And interestingly, elements from the birth canal can be in there too, like vernix caseosa, that waxy coating from the baby lanugo, fine fetal hair, and even meconium, the baby's first stool. Second stage is lochia serosa. This looks yellowish or pink, or maybe pale brownish. This runs typically from days 5 through 9. This stage shows a transition in healing. You see fewer red blood cells, but a significant increase in leukocytes, white blood cells, wound exudate, cervical mucus, and microorganisms, bacteria. Now, it's really important to note here that the presence of bacteria at this stage is not automatically pathological unless it's associated with other clinical signs of sepsis, like fever or pain. Then the third stage, lochia alba. This is a pale white discharge. It runs from about day 10 through day 15, sometimes a little longer. This represents the final stage of healing and tissue reorganization. Its composition is rich in decidual cells, loads of leukocytes, mucus, cholesterol crystals, fatty and granular epithelial cells, and again, microorganisms.
That's a very clear progression. So, given that the composition changes so dramatically, what are the most critical clinical warning signs related to lochia that a professional would be looking for when inspecting, say, the vulvar pads?
Okay, several key red flags. First and most immediate is the odor. If it becomes truly malodorous, really foul-smelling, that strongly indicates infection, specifically puerperal sepsis, or sometimes a retained cotton plug or swamp. Second is the amount. If the lochia is suddenly very scanty or seems absent altogether, that could suggest something called lochiometria, basically, a collection of infected fluid trapped inside the uterus, maybe blocked by a clot. Conversely, if it's suddenly excessive or flooding, that often points towards infection causing poor uterine contraction or even active bleeding. Third, and perhaps most diagnostically critical, is the color persistence. If that bright red color of lochia rubra persists beyond the normal limit, say past day 4 or 5, that's a strong signal. It points towards either subinvolution, the uterus isn't shrinking properly, or more dangerously retained bits of conceptus. That means placental fragments or membranes left behind, which require immediate intervention, usually DNC, dilation, and curettage. And on the flip side, if lochia alba, the white discharge, persists well beyond 3 weeks, that suggests there might be a local genital lesion, maybe an ulcer or infection in the cervix or vagina that needs further investigation. #NADV. General physiological systemic changes.
Okay, we focused heavily on the pelvic region, but the systemic reset of the entire body, not just the pelvis, must be tremendous during this time. Let's look at those general physiological changes, starting with the circulatory and hematological system. What happens there?
Oh, absolutely. The cardiovascular system has to rapidly adjust, mainly to losing that low-resistance placental circuit it was applying. So the pulse rate is watched closely. It might be slightly raised for a few hours right after delivery, but it should settle back to normal baseline by the second day. It might temporarily spike, though, during excitement or with those after pains we'll discuss later. Temperature surveillance is also mandatory. The temperature really shouldn't exceed 37.2 degrees Celsius, that's 99 degrees Fahrenheit, within the first 24 hours. There might be a slight reactionary rise, maybe half a degree Fahrenheit, but that should normalize within 12 hours.
Yeah.
Now, a slight rise on the third day is often blamed on breast engorgement coming in, but, and this is a key clinical takeaway, this should never last more than 24 hours. And crucially, a genitourinary tract infection must always be ruled out first before attributing any fever to something like breast engorgement. You have to exclude infection.
That's a vital point. Okay, pregnancy required a massive expansion of blood volume and cardiac output. How quickly does the system scale back down?
Right, that expansion reverses pretty quickly. Blood volume decreases slightly in the immediate period due to blood loss during delivery and some dehydration from labor, but it generally returns to non-pregnant levels relatively fast, usually by the second week. Cardiac output, though, sees a really dramatic jump immediately after delivery. It can go up to 80% above the pre-labor value. That's because the pressure release from the delivered placenta sends a surge of blood back into the general circulation. This temporarily high output then slowly returns back to normal within about 1 week.
Wow, an 80% jump. And what about the blood components themselves? The body's stress response and, maybe most importantly, the risk of blood clots, thrombosis. That must be managed carefully.
Absolutely critical. The stress of labor itself induces leukocytosis, a high white blood cell count. It can reach up to 25,000 per cubic millimeter, which is quite high. But the major risk area, as you said, is coagulation. That hypercoagulable state, the increased tendency to clot that was established during pregnancy for protection against hemorrhage, actually persists for about 48 hours postpartum. Furthermore, there's a secondary, more prolonged risk. This comes from an elevation in both platelet count and fibrinogen levels, which can persist up to the second week postpartum. This definitely increases the potential for dangerous conditions like deep vein thrombosis, DVT, and pulmonary embolism. However, the body has this fascinating built-in protective mechanism running in parallel. This high thrombosis risk is simultaneously balanced by enhanced fibrinolytic activity that's the body's ability to naturally break down blood clots. And this clot-busting activity is actually enhanced during the first 4 days postpartum. This fine-tuned balance between clotting and breaking down clots is precisely why early ambulation, getting the mother moving, is so critical. It helps push the system towards safety.
That dual regulation increasing clot risk while also boosting clot breakdown, that's just brilliant physiological engineering, isn't it? Amazing balance. Okay, now let's talk fluid balance. The body retains liters and liters of extra fluid during pregnancy. How does it get rid of all that volume?
The main mechanism is a pronounced diuresis, which just means increased urine production. This typically kicks in noticeably on the second or third day postpartum. There's a net fluid loss of at least 2 liters during the first week alone, and then an additional 1.5 liters over the next 5 weeks, so quite a significant fluid shift. Interestingly, our source notes this fluid loss is even larger in women who had conditions involving fluid retention during pregnancy, like preeclampsia or eclampsia. Their bodies have even more to shed.
And what does this mean for the urinary tract itself? Does it cope okay?
Well, the urinary tract undergoes some pretty profound temporary changes. The bladder mucosa, the lining, often becomes edematous, swollen, and hyperemic, meaning increased blood flow. Bladder capacity increases significantly. But critically, women commonly experience overdistension of the bladder without feeling the usual urge to void. The sensation is dulled. This, coupled with potentially incomplete emptying and leaving residual urine behind, results in urinary stasis urine just sitting there. And this is reported in more than 50% of puerperal women. The stasis makes the puerpera highly susceptible to urinary tract infections, UTIs. That's why encouraging early voiding and keeping an eye on output is so essential. Also, the dilated ureters and renal pelvis to tubes from the kidneys and the collecting area in the kidneys, which expanded during pregnancy, usually take about 8 weeks to fully revert back to their normal non-pregnant size.
8 weeks for the ureters. Okay. Finally, for systemic changes, the GI tract. We mentioned earlier that constipation is a common complaint. What causes this? It seems multifactorial.
Yes, constipation is very common. Several things contribute. There's often increased thirst and some dehydration from fluid loss during labor, leading to harder stools. There's also delayed gastrointestinal motility, things just move slower, and even a mild temporary ileus, a sort of paralysis of the bowel right after delivery. Combine that with general perineal discomfort, maybe soreness from stitches, or even the fear of tearing sutures, all of which discourages bearing down. And you can see why constipation often requires some intervention, like stool softeners or laxatives. The source also notes, unfortunately, that some women may experience temporary issues with anal incontinence as well, due to nerve or muscle stretching during delivery.
Okay. And the overall weight loss picture, beyond the baby and placenta.
Right. The initial loss is significant, about 5 to 6 kilograms. That's the weight of the fetus, the placenta, the amniotic fluid, and immediate blood loss. Following that initial drop, there's a further loss of about 2 kilograms, or roughly 4.4 pounds, that occurs during the puerperium itself. This is primarily due to that massive diuresis, shedding all that extra fluid, and the loss of stored pregnancy fat. That often continues slowly, sometimes for up to 6 months postpartum.
All right, we've covered the huge physical reset. Now we absolutely must turn to the hormonal landscape. Those massive levels of pregnancy steroids have crashed. This allows the ovarian cycles to eventually resume. So, when does fertility typically return for mothers who are not lactating?
Yeah, the return of fertility is highly individual, of course, but it follows pretty predictable hormonal patterns. In non-lactating mothers, menstruation usually returns by the 12th week postpartum in about 80% of cases. The average timing is somewhere between 7 and 9 weeks. But here's the crucial clinical detail for counseling. Ovulation, the release of an egg, may occur as early as 4 weeks postpartum. This means a woman can potentially become pregnant again before she even experiences her first menstrual period after delivery. That timing is critical to understand for contraception.
Wow, as early as 4 weeks. That is a critical timing issue for counseling. Okay, what about the mechanism for fertility suppression in mothers who are lactating? How does breastfeeding delay things?
Right, for lactating mothers, the return is significantly delayed, generally speaking. Ovulation typically occurs later, maybe around 10 weeks after delivery on average. But the total duration of amenorrhea, no periods, and an ovulation, no ovulation, depends strictly on the breastfeeding behavior itself. The key physiological basis is the elevated levels of serum prolactin, that's the milk production hormone. High prolactin levels triggered by the suckling reflex suppress the hypothalamic pituitary ovarian axis. Basically, it stops the normal hormone cascade needed for ovulation. Now, to maintain this natural contraceptive effect, the breastfeeding has to be frequent, intense, and sustained. Specifically, the guidelines mention more than 8 times within a 24-hour period. If a mother is exclusively breastfeeding like this and remains amenorrheic, it provides about 98% contraceptive protection for the first 6 months postpartum. It's called the lactational amenorrhea method, or LAM. However, because there's variability between individuals and because ovulation can still precede the first period in about 1/3 of women, even with breastfeeding, contraceptive guidance is always necessary, regardless. You can't rely on LAM indefinitely, or if feeding patterns change.
Good clarification. Always need backup eventually. Okay, finally for hormones, a quick note on the thyroid gland. That's an organ that works pretty hard during pregnancy. How does it reset?
Yes, the thyroid is definitely impacted. Thyroid volume gradually regresses back to the pre-pregnant size over about 12 weeks. Functionally, the levels of thyroid hormones typically return to normal by about 4 weeks postpartum. And this is an essential point for clinical management. Women who are already on thyroid medications, say for hypothyroidism, must have their thyroid function checked in the early puerperium. Their dosage almost certainly needs to be readjusted downwards, as their physiological needs for replacement therapy change dramatically once the demands of pregnancy are gone. That's a key follow-up point. #tag-your-mother, the deep dive into lactation physiology.
Okay, now we address the one system that doesn't really involute, but instead transitions into full production mode. The mammary glands, the breasts. Before mature milk comes in, we have colostrum. What exactly is the composition of this vital first secretion?
Right, colostrum. It's secreted for the first 2, maybe 3 days postpartum. It's typically a deep yellow color, quite viscous, almost a serious fluid. It's alkaline and has a high specific gravity. Nutritionally, it's quite different from mature breast milk. It's very high in protein, vitamin A, sodium, and chloride. But it's actually lower in carbohydrate, fat, and potassium compared to later milk. Microscopically, if you were to look at it, you'd see fat globules and also these specialized cells called colostrum corpuscles.
Okay.
These are essentially large polynuclear leukocytes, white blood cells that have engulfed numerous fat globules.
Fascinating. High protein, different minerals. What are the specific advantages of providing this first milk to the newborn? Why is it so important?
2 main advantages, really. The primary one is immunological defense. Colostrum is absolutely packed with antibodies, specifically high concentrations of immunoglobulin A, IgA, immunoglobulin G, IgG, and immunoglobulin M, IgM. It also contains critical humoral factors like lactoferrin. Basically, it provides powerful passive immunity right when the newborn's own immune system is just starting to ramp up. It's like their first vaccination. Secondly, because of the nature of those large fat globules, colostrum has a significant laxative action. This helps the infant pass meconium, that sticky first stool, and also helps clear bilirubin from the intestines, which can help prevent neonatal jaundice. So immune protection and helps clear the gut.
Immune boost and a laxative. Got it. Okay, let's break down the 4 defined phases of lactation itself. You mentioned perfect endocrine choreography is required here.
Yes, it's a beautifully orchestrated process. The 4 phases are 1, mammogenesis, that's the preparatory growth phase during pregnancy. 2, lactogenesis, the actual synthesis and secretion of milk. 3, galactokinesis, the ejection or letdown of milk. And 4, galactopoiesis, the maintenance of established lactation. So mammogenesis involves that remarkable growth of the ductal system and the lobular-alveolar system, the milk-producing units throughout pregnancy. Hormones drive this. A crucial physiological detail here, mentioned in our source, is that an intact nerve supply to the breast is not essential for this structural preparation. The hormones do the work.
Okay, preparation happens during pregnancy. Then comes lactogenesis, the actual start of milk secretion, usually kicking in around the third or fourth postpartum day. Breasts often feel full, tender. The key question here is, why doesn't the milk flow during pregnancy when prolactin levels are already really high?
That's the function of the hormonal breaks. During pregnancy, you have high circulating levels of steroid hormones, estrogen and progesterone. These steroids make the fully developed breast tissues essentially unresponsive to that high prolactin. Milk secretion is effectively suppressed. But once the placenta is delivered, those steroid levels plummet rapidly. The brakes are released. This allows prolactin to finally exert its effect and begin secretory activity on the now prepared glandular tissue. The key hormones driving this actual synthesis phase are prolactin itself, but also insulin, growth hormone, and glucocorticoids. It's a team effort.
Hormonal breaks off, milk synthesis starts, then comes the mechanical process of actually getting the milk out to the baby, galactokinesis, the ejection or letdown reflex. This is more than just the baby sucking, right? There's an active process.
Absolutely. It requires a contractile mechanism. And this is where oxytocin comes in as the major galactokinetic hormone. What happens is, suckling by the infant initiates a conditioned neurohormonal reflex. It's quite complex. Tactile impulses from the nipple and areola travel up via the sensory neural arc, specifically involving the T4, T5, and T6 nerve segments to the hypothalamus in the brain, specifically the paraventricular and supraoptic nuclei. The hypothalamus then synthesizes oxytocin and transports it down nerve fibers to the posterior pituitary gland, where it's released into the bloodstream. Oxytocin then travels to the breast and causes the contraction of the myoepithelial cells. These are tiny muscle cells that actually surround the milk-producing alveoli and the ducts. This contraction physically squeezes the milk out of the alveoli and forces it down into the lactiferous duct ampulla, making it available to the baby. It's a sensation the mother often recognizes as the draft or letdown. And this reflex is so conditioned it can even be triggered just by the sound of the infant's cry, or even seeing the baby, or thinking about feeding.
That detailed neurological pathway. It really explains why the mother's psychological state can interfere so much, what factors can inhibit this letdown reflex.
Yes, it's very sensitive. Things like pain, maybe from sore nipples or after pains, high anxiety, significant stress, adverse psychological states like depression, or even just severe physical breast engorgement. All of these can significantly inhibit the release of oxytocin from the pituitary. This can lead to deficient milk ejection, meaning the milk is there but can't get out effectively, sometimes for several days, even if synthesis is adequate.
Mind-body connection is strong there. Okay, finally, phase 4. Galactopoiesis. This is the maintenance phase, keeping milk production going long-term. How is sustained production regulated?
Prolactin remains the single most important hormone for maintaining milk production. But the key requirement for effective continuous lactation is frequent and effective removal of milk from the breast, primarily through suckling. The recommendation is usually more than 8 times in 24 hours, especially early on. The maintenance mechanism is highly responsive to demand. It's a supply and demand system. Production will actually fail or decrease if milk transfer is inadequate. Why? Because distension of the alveoli by retained milk just sitting there, causes back pressure that actively reduces the rate of further milk synthesis. The factory needs constant emptying to keep running at full capacity. Remove milk frequently. Make more milk.
Supply and demand. Okay, a healthy mother produces a significant amount of milk daily. What's the metabolic cost of that, and what are the common clinical reasons for inadequate production or lactation failure?
Yeah, the output is substantial. A healthy mother typically produces between 500 and 800 milliliters of milk per day. That requires a hefty caloric intake, about 700 extra kilocalories per day on average. Often, this energy is mobilized, at least partly, from the fat stores accumulated during pregnancy. Now, inadequate production, or perceived inadequate production, is often due to simply infrequent or ineffective suckling, maybe a poor latch or not feeding often enough. Less commonly, it can be due to endogenous prolactin suppression caused by certain drugs. The source mentions ergot preparations, high doses of pyridoxine, vitamin B6, or some diuretics. Retained placental bits can also interfere. But crucially, the source emphasizes that pain and anxiety are often hidden factors leading to lactation failure, likely by inhibiting that oxytocin letdown reflex we discussed.
And what if milk suppression is actually medically required, say in tragic circumstances like a stillbirth, or if the mother has a condition where breastfeeding is contraindicated? What's the safest protocol, according to our source?
This is critical. The source strongly advises against medical suppression using drugs, primarily due to the severe risks associated with them. The preferred and safer method involves non-medical approaches. Stop all feeding and pumping immediately. Wear a firm, supportive bra continuously. Use ice packs on the breast to reduce swelling and discomfort. Take simple analgesics like aspirin or ibuprofen for pain and engorgement management, and apply a tight compression bandage around the breast for 2 to 3 days. This allows natural physiological inhibition, the back pressure from retained milk, to gradually shut down production. The risk of using medical suppression drugs like estrogen or bromocriptine is just too high. They carry documented risks of severe side effects, including dangerous cardiovascular events like severe hypotension, myocardial infarction, heart attacks, seizures, and even puerperal stroke. So the non-medical route is considered the only truly safe one. Avoid the drugs if at all possible. #8fit. Management of normal puerperium and postnatal care.
Okay, let's move now into the practical clinical management of a normal puerperium. What are the primary goals guiding the care of the mother during these crucial 6 weeks?
The management principles are pretty robust and focus on 4 key areas. First, simply restoring the mother's overall physical and mental health. Second, actively preventing infection, which remains a significant risk during this recovery period. Third, promoting successful breastfeeding, if the mother chooses to, and ensuring proper breast care to avoid complications like mastitis. And fourth, providing comprehensive counseling on effective contraception and family planning before the mother leaves initial postnatal care. Getting that sorted early is important.
We mentioned earlier that early ambulation, getting the mother moving, is really beneficial. Can you detail the specific advantages again? Why is getting out of bed relatively soon so important?
Yes, early ambulation is strongly encouraged. Getting the mother out of bed soon after delivery, once she's stable, provides several benefits. It gives a psychological boost, a sense of well-being. It helps minimize bladder complications like retention and bowel issues like constipation. It also facilitates uterine drainage, helps the lochia flow out, and that actually hastens involution, the shrinking process. But arguably, the most significant clinical advantage is the reduction in the risk of puerperal venous thrombosis and embolism. Getting those leg muscles working prevents venous stasis, blood pooling in the legs. Combine that movement with addressing the mother's temporary hypercoagulable state, and you drastically reduce the risk of potentially deadly blood clots forming in the legs or traveling to the lungs. Movement is key.
Okay, movement is key. For specific systemic care, the source really emphasizes watching the bladder, given that high risk of urinary stasis you mentioned. What's the precise protocol if a patient is struggling to void?
Right, because of that increased bladder capacity and decreased sensation, the patient really must be encouraged to try and void as soon as possible after delivery and regularly thereafter. If she fails to pass urine adequately, or if the clinical signs suggest incomplete emptying, which can be confirmed by measuring the residual urine volume after voiding, typically with ultrasound or a quick catheterization, and finding more than 60 milliliters left behind, then catheterization is necessary. This is done to prevent urinary stasis, which breeds infection, and also to help restore normal bladder tone. If the problem is persistent, sometimes continuous catheter drainage might be maintained for a day or two until bladder tone is demonstrably regained. This proactive management is really essential to combat that high, over 50% risk of urinary stasis and potential UTI.
Proactive bladder care, got it. Now, hygiene and wound care, particularly important if there was an episiotomy or a tear that required stitches. What's the advice?
Cleanliness and asepsis preventing infection are absolutely paramount, especially in that first week when tissues are most vulnerable. The vulva should be gently washed with soap and water regularly, and a clean, sterile pad applied and changed frequently. Any perineal wound from an episiotomy or tear should be carefully cleaned and dressed. The source mentions using spirit or an antiseptic powder after each act of micturition and defecation, or at minimum, twice daily. Keep it clean and dry. For pain relief from stitches, cold sitz baths using ice are highly recommended. The cold causes vasoconstriction, which reduces the edema, swelling, and inflammation at the suture site, providing significant comfort. Now, if pain is persistent or worsening despite these measures, an examination must be performed immediately to rule out a developing vulvovaginal hematoma, a collection of blood under the skin. And simple analgesics like ibuprofen, which is safe for nursing mothers, can be prescribed for pain management.
Okay, good wound care advice. And maternal-infant bonding is also highlighted as part of immediate care, often promoted through rooming in. Tell us about that.
Yes, bonding is considered a crucial part of the psychological aspect of the puerperium. It ideally starts with immediate skin-to-skin contact after birth, followed by lots of close contact kissing, cuddling, gazing at the infant. Rooming in, which means keeping the baby in a cot right near the mother's bed rather than in a separate nursery, is strongly encouraged. It not only strengthens this crucial emotional relationship, but also rapidly educates the mother on her baby's care cues, feeding patterns, and just the practical art of nursing and handling her newborn. It builds confidence.
Makes sense. What about preventing common breastfeeding issues? The source mentions nipple confusion. What is that and how do you avoid it?
Right, nipple confusion. This happens sometimes when a newborn is given both the breast and an artificial nipple from a bottle or pacifier very early on. The infant might then seem to accept the artificial nipple, but start refusing or struggling to latch onto the mother's breast. The sucking mechanics are different. To avoid this, mothers are generally advised to avoid supplemental feeds with bottles, especially in the first few days or weeks while breastfeeding is being established, unless medically necessary. Additionally, if the mother's nipple isn't very protractile, there are techniques to help make it easier for the baby to latch onto before feeding starts. Consistency with breastfeeding technique early on is really key to establishing a strong, effective latch and ensuring good milk transfer and production.
Avoid mixed signals early on. Got it. Finally, for immediate postnatal care, what essential immunizations need to be administered or checked before discharge?
3 key immunizations are typically managed in the immediate postpartum period before the mother goes home. First, anti-D-gamma globulin, like Rojam. This must be administered to unimmunized rhesus-negative mothers who have just delivered rhesus-positive babies. This prevents the mother from developing antibodies that could harm future Rh-positive pregnancies. It's usually given within 72 hours. Second, women who are found to be susceptible to rubella, German measles, can be safely vaccinated postpartum with the live attenuated rubella virus vaccine. However, it's crucial they understand they must commit to effective contraception to postpone any subsequent pregnancy for at least 2 months after receiving this live vaccine. Third, booster doses of tetanus toxoid, hepatitis B, and especially Tdap, tetanus, diphtheria, and acellular pertussis for whooping cough protection for the baby should be offered if the mother didn't receive them during pregnancy. All of these are considered safe to receive while breastfeeding. #TagZoneMinds exercise and postnatal follow-up.
Okay, even in a totally normal recovery, some minor ailments are pretty common in the puerperium. Let's start with after pain. Why does breastfeeding seem to trigger it, and why is it often worse in women who had babies before multiparas?
Yes, after pains. They're that infrequent sort of spasmodic, cramp-like pain felt in the lower abdomen, usually for the first 2 to 4 days postpartum. They are indeed more common and often stronger in multiparas. The thinking is that their uterine muscles have lost some tone compared to first-time mothers, so the uterus has to contract more forcefully and intermittently to clamp down effectively, especially to expel any accumulated blood clots or small retained fragments. And yes, they are often triggered or intensified during breastfeeding. That's because suckling stimulates the release of oxytocin from the pituitary gland. Oxytocin not only causes milk letdown, but is also the primary hormone responsible for causing uterine contractions. So feeding directly stimulates these cramps. Treatment usually involves gentle uterine massage to help expel any clots, making sure the bladder is empty, and then simple analgesics like ibuprofen, which works well. Sometimes antispasmodics might be considered if they're very severe.
Oxytocin doing double duty there. Okay, correction of anemia is also mentioned as a standard part of management.
Absolutely. Anemia, whether pre-existing or resulting from blood loss during delivery, needs to be proactively addressed. It impacts the mother's energy levels, healing, and overall well-being significantly. Supplementary iron therapy, typically with something like ferrous sulfate 200 milligrams daily, is recommended for a minimum period of 4 to 6 weeks postpartum to rebuild iron stores, sometimes longer depending on the severity.
Right, rebuild those stores. Now, let's look at longer-term recovery through the recommended postpartum exercise program. Our source says it should continue for at least 3 months. What are the specific structural benefits?
Yes, continuing those exercises is really important. The objectives are primarily twofold. First, improving muscle tone, specifically focusing on the abdominal and the perineal pelvic floor muscles, which were obviously severely stretched and potentially injured during pregnancy and birth. Second, educating the mother on correct posture, safe lifting techniques, and good body mechanics for daily activities. The advantages are quite significant and go beyond just getting back in shape. Regular pelvic floor exercises help minimize the risk of future problems like genital prolapse and stress incontinence of urine. Strengthening the core helps prevent chronic backache, which is often related to posture and weak abdominals after pregnancy. And general exercise boosts circulation, which continues to minimize the risk of peripheral venous thrombosis. So the benefits are long-term health and prevention. And yes, a minimum duration of 3 months is usually recommended to see meaningful effects on muscle strength and support.
Okay, 3 months minimum. Can you detail the procedure again for specifically toning those crucial pelvic floor muscles and the abdominal wall?
Sure. The program typically starts gently, often while still in the hospital, with basic breathing exercises and simple leg movements while lying down. Then the focus shifts to toning the pelvic floor muscles, often called Kegel exercises. The instruction is usually to contract the muscles as if trying to stop the flow of urine midstream or trying to prevent passing gas. Hold the contraction for a few seconds, then relax. This should be repeated frequently throughout the day, building up duration and repetitions. To tone the abdominal muscles, a common starting exercise is for the patient to lie on her back with her knees bent and feet flat on the bed. Then she consciously contracts her abdominal muscles, pulling her belly button towards her spine, holds briefly, and relaxes. This can gradually progress to more challenging core exercises. For back support, an exercise might involve lying face down and gently lifting the head and shoulders off the bed slightly, holding and lowering, again gradually increasing repetitions. It's all about progressive strengthening.
Progressive strengthening, got it. Finally, we reach the crucial 6-week postnatal checkup. This appointment really marks the culmination of the puerperal period. What are the main clinical aims, beyond just a basic physical health assessment?
That 6-week checkup is really comprehensive, or should be. The aims are multifaceted. We assess the mother's overall health status, making sure any pre-existing medical conditions like diabetes, hypertension, thyroid disorders are stable, and medications are appropriately adjusted now that she's postpartum. We specifically look for and treat any gynecological conditions that might have arisen as a direct result of the pregnancy or birth, the obstetric legacy, so to speak. We also review the baby's progress, check on feeding, and make sure the immunization schedule is on track. And perhaps most crucially from a public health perspective, we impart comprehensive family planning guidance and help the mother choose and initiate a suitable contraceptive method if desired.
Okay, that contraception guidance is key. And it must be strictly tailored based on breastfeeding status, primarily because of that risk of milk suppression from certain hormones. Can you walk us through the specific methods and timing differences again?
Yes, this is a really critical distinction in practice. For women who are not lactating, contraception can generally be safely started at around 3 weeks postpartum. And combined steroidal preparations, the standard combined estrogen-progestin birth control pill, patch, or ring, are usually suitable options. However, for mothers who are lactating, especially exclusively, contraception initiation is often delayed slightly, maybe started around 6 weeks or even later, depending on the method. And combined steroidal preparations containing estrogen must be avoided entirely. This is because estrogen has well-documented suppressive effects on milk volume and potentially composition. So for breastfeeding mothers, the better non-suppressive choices are progestin-only methods. This includes the progestin-only pill, the mini pill, injectable DMPA, dipomedroxyprogesterone acetate, or progestin-releasing implants like levonorgestrel implants. These are all preferred because they do not interfere with lactation. It's also worth re-mentioning the lactational amenorrhea method, LAM, which provides high but not perfect protection for up to 6 months if criteria are strictly met. Exclusive breastfeeding, amenorrheic, baby 6 months. And IUDs, intrauterine devices, both copper and hormonal progestin-releasing, are considered a satisfactory and effective method irrespective of breastfeeding status. They have no impact on milk supply. There are actually several options for IUD insertion timing. Immediately post-placental, right after delivery, within 10 minutes, within 48 hours of delivery, during a cesarean section if one is performed, or the standard 4-6 week postnatal checkup.
Lots of options, but clear differences based on lactation. Okay, before we conclude, let's quickly touch on those common gynecological legacy issues that might be identified at that 6-week checkup. For instance, what if there's irregular bleeding?
Right. Irregular vaginal bleeding presenting around the 4 to 6 week mark is quite common. In non-lactating women, this is very often simply the return of the first menstrual period, and reassurance is usually all that's needed after confirming involution is complete. However, if the bleeding is unusually heavy or persistent and seems to date right back to the time of childbirth, it becomes more suspicious. It could indicate retained products of conception, placental fragments, or membranes. This requires investigation, often an ultrasound, and may necessitate a dilation and curettage D&C procedure to clear the uterus. Another common finding at the checkup is cervical ectopi, sometimes called erosion. This is where the glandular cells from inside the cervical canal are visible on the outside surface. Hormone-induced ectopi from pregnancy often takes about 12 weeks to regress spontaneously as hormone levels normalize. So if ectopi is seen at 6 weeks and it's asymptomatic, not causing bleeding or discharge, the advice is usually to wait and re-examine after another 6 weeks, at 12 weeks postpartum, before considering any treatment like cauterization. Give the body time to sort it out naturally. Finally, issues like a slight degree of uterine descent or mild stress incontinence, leaking urine with cough sneeze, are often significantly improved or even cured simply by effective adherence to those pelvic floor exercises we discussed. Diligent Kegels really can make a difference. Marked prolapse, however, where the uterus or vaginal walls are significantly descended, usually requires surgical correction. But this surgery is typically deferred until at least 3 months postpartum, sometimes longer, to allow for maximal natural involution and tissue recovery before surgical repair is attempted. #tag outro.
Well, we have certainly achieved a deep dive into mastering the puerperium, that incredible 6-week biological reset. We've covered the staggering anatomical scale, that uterus shrinking from a massive 1,000 grams down to just 60 grams. We explored the almost surgical efficiency of autolysis driving muscle breakdown at the cellular level, the rapid restoration of the endometrium lining by day 16, and that critical hormonal choreography underpinning lactation, the clear divide between prolactin driving milk synthesis and oxytocin needed for milk ejection. It's truly intricate.
It really is.
Yeah.
And if we try and connect this profound physiological rebound to the wider medical context, the sheer systemic reorganization, everything from coagulation factors normalizing to fluid shifts to that crucial lifting of pregnancy-induced immune suppression, it represents a massive physiological shift across the entire body. And our sources even highlight that this rebound effect of the immune system as it comes back online can sometimes cause a flaring response in certain pre-existing autoimmune disorders that might have been quieter during pregnancy. So this raises, I think, an important question for you, our listener, to perhaps explore further. Given the precise, rapid, and measurable nature of many of the puerperium's physiological markers, things like the urea and creatinine excretion from uterine autolysis, the shifts in fibrinolytic activity, the predictable need for thyroid dose adjustments, how might future personalized medicine potentially utilize these highly detailed, predictable 6-week biological shifts, not just to monitor recovery, but perhaps to proactively prevent or better manage the rebound or flare-up of chronic non-obstetric conditions in the mother as her body undergoes this intense period of reversion. Food for thought.